Greetings, hello, and welcome. Now, imagine a hidden tangle of blood vessels in your brain, silently pulsing under pressure. One could rupture at any moment. That's the danger of brain arteriovenous malformations, or AVMs. A brain AVM is a congenital anomaly, meaning you're born with it, where arteries connect directly to veins without the usual capillary bed in between. This creates a high-flow, high-pressure system that puts delicate brain vessels at risk of rupture. The core of this malformation is called a nidus. Brain AVMs are relatively rare, but they can be devastating. Many people don't know they have one until it bleeds. AVMs usually form during fetal development, but they often go unnoticed until symptoms appear, often between the ages of 20 up to 40. So what are the symptoms to watch out for? The most common presentation is bleeding. An AVM can rupture, causing a hemorrhagic stroke, leading to sudden headache, weakness, seizures, or loss of consciousness. Other symptoms might include chronic headaches, seizures, or subtle neurologic deficits if the AVM compresses surrounding brain tissue. Now, how is it diagnosed? A CT scan is often the first test in the emergency setting, especially if there's a history of bleed or bleeding. An MRI or an MRA provides a detailed image of the AVM and the surrounding brain structures. But the gold standard is digital subtraction angiography, DSA. It maps out the AVM in exquisite detail, the feeding arteries, the nidus, and the draining veins. So what are the treatment options? There is no one-size-fits-all solution. Management depends on the AVM size, its location, and its rupture status, and the patient's overall health. Common strategies include, number 1, microsurgical resection, which is complete removal of the AVM. This is ideal for smaller, superficial lesions in non-eloquent brain areas. The second is endovascular embolization. A catheter delivers material like onyx to block off feeding vessels. This is sometimes curative. It's often used as an adjunct to surgery or radiosurgery. And speaking about radiosurgery, we have stereotactic radiosurgery. This is focused radiation like gamma knife, which causes gradual closure of the AVM over 1 to 3 years. This is best for small, deep, or surgically inaccessible AVMs. Then we have a multimodal approach. Here's where we combine embolization with surgery or radiotherapy to optimize results in complex cases or deep AVMs. And lastly, we have observation. In some cases, especially unruptured AVMs, conservative management is chosen. This is supported by studies like the ARUBA trial, which questioned the benefits of intervening in asymptomatic AVMs. So what happens if we do nothing? If untreated, ruptured AVMs carry a high risk of disability or death. Treated AVMs, when completely obliterated, greatly reduce the risk of rebleeding. However, each treatment comes with its own risks, including stroke, infection, or incomplete AVM closure. So, brain AVMs are a silent threat, unpredictable, but potentially treatable. Advances in imaging and interventions have made it possible to manage them more safely than ever. But the key lies in careful diagnosis, individualized treatment planning, and understanding when to act and when to watch. Know the risk, know the options with AVM, and remember, awareness can save lives. Have a blessed day.